Good evening, everybody. Thank you, Dr. Bharti Kashyap, to giving me opportunity. Now, my topic is to defend trifocal IOL implantation in unilateral cataract. So, in disclaimer, I should say I have no personal interest or personal preference to any person or product, no financial disclosure, and purely what we will be talking on my personal opinion backed by literature and personal experiences. The Herculean task to argue Dr. Shuja because he is a well-known personality in Eastern India and experienced, versatile, high-volume phacosurgeon. The various presentation of unilateral cataract is associated cataract in congenital syndrome, secondary cataract, traumatic cataract, most common cause in young individuals, posterior subcapsular cataract, pediatric cataract, and idiopathic cataracts. The unilateral cataract causative factors, if you look into, these are asymmetric aging, glaucoma, or uveitis. Rate of progression may differ in the prolonged use of ultraviolet radiation from sun, smoking, of course, corticosteroid, diabetics, trauma. Usually younger patients more adaptable, and in case of more than 50, second eye to be done at an early stage. These are the different presentations of the unilateral cataracts. Now, when you think about and ask the patient, what do you want actually? We should ask the patient, what do you want? The patient invariably, the answer is the spectacle independence. Now, how to get rid of the spectacles? There are various literatures. The literature says the unilateral implantations is a very good literature evaluation of vision-related quality of life after unilateral implantation of trifocal intraocular lens. The unilateral implantation of trifocal IOL is well tolerated with good patient satisfaction, assessed by visual function. 14 questionnaires in subject to that the cataract have in one eye, encouraging single-eye surgical procedure in this particular group of patients. There are other literatures like the rate of complete spectacle independence with trifocal intraocular lens. This meta-analysis of 13 unique clinical studies demonstrated that at least 9 out of 10 patients receiving trifocal IOL during cataract surgery can expect to achieve complete spectacle independence. Now, the congenital cataracts, the exclusion criteria are the glaucoma, retinal pathologies, and systemic problem, of course, but the trifocal IOL implantation should be considered as an alternative to monofocal lenses in selected cases of pediatric cataract where amblyopia is not subjected. So, the one more study is a good study, the trifocal toric intraocular lens implantation in pediatric traumatic cataract, which says that in careful selected pediatric patients with traumatic cataract, trifocal toric intraocular lenses may offer some benefit over the standard monofocal lenses. This is one more study of visual preference performance with monofocal, accommodating, and multifocal intraocular lenses in patients in unilateral cataract. Mind it, I'm talking about this literature, this article about the multifocal intraocular lens. This is far now, we are reaching far more than we are reaching the trifocal, the modern trifocal IOLs. This study says in the group 2 and group 3, multifocal IOL provide better stereopsis, higher spectacles independence rates, and satisfactory functional vision over a broad range of distances in presbyopic patients with unilateral cataract compared with the monofocal and accommodated IOLs. So in the idiopathic cataract, unilateral cataract, the post-cataract surgery in unilateral cataract, the trifocality is a must, and possibilities of other eye, refractive error, if there is an refractive, but will be happy with progressive and bifocal glasses. If the patient becomes motivated for the other eye surgery, the choice of IOL should be trifocal. This is my personal one patient, which under the high myopic patients, you see the pre-op cases, pre-op the condition of the eye, and the patient was received a trifocal of 10 diopter, and the patient is getting a vision of 6, and 6. So but we are now reaching to the end of trifocal. This is a high-end trifocal now. The asymmetric stretching of the super Gaussian profile, optimized contrast and clarity is different in light conditions and tailored in wearer visual needs, and undulated of the surface reduces the halos and glare drastically compared to the traditional trifocal. So we are reaching now the end of tri. So the EDOF light distribution results in the minimum losses and optical light distribution with the conventional trifocals. We are reaching maybe this is the end of the, this is the in time, it will be the popular EDOF tri. So in conclusion, operating the other eye at earliest if possible, patients wanting for refractive lens exchange is to be considered. Unilateral implantation of the trifocal IOL in patients with unilateral cataract could provide good distant, intermediate, and near vision with good patient satisfaction and vision-related daily activity performance regardless of the presbyopic status of the fellow eye. So in conclusion, treat the patient as per requirements. Should not be a biased decision or follow blindly. Patients should be provided with what is best in today's scenario. Proper planning and execution of the surgeon's skill is important. Quality should score over the quantity of the surgery. Decisions should be backed by proper evidences. And for spectacle independence, trifocal IOL is a very good option. So we have best skill, best technology, best setup, best machine, best option, high expectation of patient. So why to compromise? Thank you. Now it is the decision, it should be the decision of the house and the decision of the expert panels to choose which one, the older version or the newer thing coming in the market or has been accepted overall. Thank you. Thank you very much.
So now I request Dr. Kudlu for his expert comment.
Yeah, well, intraocular lens in unilateral cataract. In fact, there are two options. Unilateral cataract means after doing the trifocal, then forcing the patient for other eye to get operated is the first question. But we need to always look at, sometimes patient come to you, they just want to get operated in the only one eye. They doesn't want to operate the other eye at all. So if best available options, I think I personally feel that monofocal intraocular lens is best if you are only tackling the unilateral cataract. In fact, if you tackling...
Sir, I beg to differ because the literature says the model is 2023. The two articles as literature has come into the market, two study. They state that it's irrespective of the refractive status of the fellow eye, we can go for a trifocal. If the patients want spectacle independence.
Sir, again, there is depending upon for all these premium patient, whether a trifocal or multifocal, knowing the patient's dominant eye is very, very important. Again, you need to know which eye they have developed cataract, whether in the dominant eye or whether it is in the non-dominant eye. Suppose if the patient scotopic pupil is much like a larger pupil, then if you put a trifocal in the dominant eye, the chances of glare and halos will be much, much higher. So in such cases, monofocal is the option. But thinking that, okay, preoperatively your pupil is very small, before dilated. That means you can go for trifocal even in a unilateral cataract. But the pre-op condition is also very, very important. But given an option, if you don't have any pupillometry with you and you don't have any other option to do, you don't have any other options like abrometers like eye trace, which really find out how much is the angle alpha for that particular patient, given the option, definitely I'll go with the monofocal. But all these conditions suits, okay, patient will having a cataract in the non-dominant eye, then of course I do think about trifocal.
How you check the dominance in after the patient has developed cataract?
Yeah, mature cataract you cannot know. But unilateral cataract nowadays, patient with even with up to 624 or up to 636, by putting in 660 chart, still you can get the dominant eye testing in such patient by correcting them with the spectacles. So the cataract patient, sometimes you can correct with the spectacle. Still with the correct spectacle option on, you can see the dominant eye. Once you know the dominant eye, then your option is different. Always I tell, you have to be dead on with the dominant eye. Non-dominant eye, you can play around with any ring lenses. Still brain tend to get adjust very fast. But dominant eye is the key here. I think I want my friend seen his opinion.
Personally, I've not started using presbyopic glasses. So if I develop cataract, I would go for the question here is which is better. Probably the debate was going whether the monofocal or multifocal is better. So the question is unilaterality of the cataract. So one option is asking the patient to go for multifocal in the other eye. That is definitely the option. And if it is a complicated cataract, definitely monofocal is what I'm going to go for. I would preferably, and the question is the neuroadaptation happening for the other eye. So I would personally go preferably go for a monofocal IOL.
So how many people of you test the pupil size and dominance of the eye before deciding the monofocal or trifocal?
I do.
Okay.
Ma'am, before.
What would you do if you have a one-eyed patient who is undergoing a cataract surgery?
Yes.
Do you prefer a multifocal for that patient or
Yeah, this is a very good
that person has only one eye?
good question, sir. Actually, one-eyed patient, if the other eye is no PL, then I'll just look at the, apart from the all other conditions with the pupillometry, and if the pupil is small, definitely I'll go. If it is like depending upon their occupation, if she is a housewife, then if she doesn't want to ride the vehicle in the night and all, then I'll go for a multifocal lens, even one-eyed patient. But given me a chance, if a one-eyed patient will come to me, ask for, doctor, I don't want to wear the glasses for most of my things. My preferred choice will be EDOF lenses, preferably the EDOF lens without rings. That is one of the most preferred lens. What I use is the EMV lens from Rayner, that is, it doesn't have a ring, which normally has got a positive spherical aberration on the haptic of the lens, which gives a perfect results. And we have to tell the patient that you may have to wear the glass for a very fine print. That is my option. Otherwise, I think the best option is monofocal, again with the cases of what Dr. Srini said that. But if he doesn't want to wear the glass, male patient, active nightlife, one night, my preferred choice will be EDOF or monofocal lens again.
What's your experience with VVT?
Yeah, VVT, normally I don't use VVT. Yeah.
So the problem here is when VVT comes under enhanced monofocal, can't call it. See, most of the people are using this distance now. It's not the computer distance. So it's I would go for a trifocal rather than.
But VVT does not have a very good near vision.
Yeah, that's.
Yeah, every patient require a intermediate and far intermediate. It is very important. When they're driving a vehicle, they should see the meter. There is a first criteria for everybody.
Yeah, even multifocals, VR surgeons say no problem. You put it. With Bharati ma'am's permission, one query for Dr. Sharon and Sir and Nidhi. For ROC inhibitors, what would be your choice, ripasudal or netasudal?
Right.
For cornea.
Okay. So this is from both my experience and what literature says. Between the two, in the effect on the cornea in terms of detergents, in terms of helping patients who have Fuchs or one of those dystrophies, both seem similar in their effect. The problem is that the amount of epitheliopathy which is seen post their usage is much more with the netasudal drop for some reason than with the ripasudal. On the other hand, ripasudal has more patients complaining of pain, irritation, redness, and having to stop the drops. So you can still give it to your patients, but warn them that they may have redness, irritation, and in that case you will be stopping. But in terms of efficacy, both are similar.
My personal experience is different. Netasudal causes a microcystic edema.
Yes.
That's because it's stronger and the detergent's effect is better. And it's worked for me in one case. I can't tell that one case it worked, but still, it was basically, I did cataract surgery in young patient, so bilateral near mature cataract. I did the cataract surgery, endothelial recompensation. Then I thought, okay, I didn't do this because I thought something went wrong with my surgery. I used everything, Viscot and everything, did the other eye. Again, this thing. So I called up my corneal surgeon, and he asked me, sir, have you put ROC inhibitor? Yes, he has been on ripasudal. He said, try netasudal, and it cleared.
Okay. That's
Clear.
Dr. Srini, I think this is the time to wind up,
Yeah.
and we should go for a group picture of
Yeah.
the fast. of the speakers and the panelists.